Welcome to our program on Clear on Health on African Health Television on TSTV. Today is International Women's Day, and so we're celebrating women around the world, celebrating our strengths, our diversity, and everything that we stand to be. With me in the studio is Dr. Samuel Ezekweri. He's an obstetrician and a gynecologist, and we'll be talking about a condition that frequently affects women. It's called...
It's the overgrowth of the smooth muscle of the uterus.
Okay, so that's what uterine fibroid is.
Yeah.
Okay, so where on the uterus can we find uterine fibroid?
Okay, fibroid has basically three layers. We have the endometrium, we have the myometrium as the inner layer, we have the outer layer called the serosa.
Yes.
And you can see fibroid in any of these.
Okay, so those are the layers of the uterus.
Yes.
Okay.
You can see the fibroid. When it's inside, we call it submucous fibroid. When it's at the middle, we call it intramural.
Yes.
Then you can have serosa.
Yes.
At times, it can even grow towards the cervix. And the blood ligament, the one that the peritoneum that covers the womb, also grow. They call it intraligamentary fibroid.
Okay, so that means it can grow outside of the uterus.
Wherever you have the smooth muscle, fibroid can grow there.
Oh, okay.
Yeah.
Can it grow in the abdomen? Can it grow in the abdominal muscle?
Yeah, what we call parasitic fibroid.
Okay.
Yes.
So that means, are we saying it traveled from the uterus to that place?
Yes, there are many theories about that.
Okay.
Yeah, there are many theories about that.
Okay. Okay, sir. Thank you for that explanation. So how common will we say uterine fibroids are?
Actually, when we look at the reproductive age women, about 25–30% of them have uterine fibroid.
Wow.
And when you use ultrasound to estimate the incidence, it's higher.
Yes.
It's higher.
Okay. So what are the risk factors, or what we call the causes of uterine fibroid?
Actually, the cause of uterine fibroid is not completely known, but
Okay.
there are what we call risk factors now,
Yes.
or associations.
Yes.
There's what we call family history of fibroid, probably in the mother, in the siblings.
Okay.
Black race, somebody of black ethnicity.
Okay.
And then obesity. Because fibroid has to do with hormone called estrogen. So anything that has to talk that hormonal milieu might give rise to fibroid.
Okay. So what age of women are affected?
When you talk about reproductive age,
Yes,
women,
I think we should define it for our viewers.
okay, now you talk about from mostly, we see mostly from 30 up. But when we talk about reproductive age, women talk about 15 to 44.
Okay.
But we see it mostly, most people from 30 up.
Okay, sir.
Yes.
So if a mother or a sister of a person has fibroid, can the person have fibroid?
Flow.
Yeah.
Normally, a period should last between 2 to 7 days, and it should just be normal. But at times, if it's becoming too heavy, comes in lumps and clots, likely there's a fibroid mass.
Okay.
If there is some mucous fibroid. And it can also present with what we call pressure symptoms.
Okay.
You know, it's a tumor. Then you begin to compress on the bladder, on the rectum, and maybe difficulty in defecating, and all those pressure symptoms might be there. And because at times somebody can also bleed from fibroid, excessive bleeding. Person can come with anemia.
Okay.
Other things it just depends on how, and it depends also where the fibroid is located.
Yes, yes. Thank you for that explanation. You mentioned, can there be painful menses with uterine fibroids? Can we associate that someone has very painful menses and say, okay, this person might have uterine fibroid?
Yeah, a lot of things can cause painful menstruation.
Yes.
Fibroid is part of it. It's not the main one, actually.
It's not the main one.
So if the menses is painful, you most likely need to investigate it.
Okay, okay. But can uterine fibroid stop someone from conceiving?
The answer is definitely no.
Okay.
Though it also depends on where the fibroid is located.
Okay.
And if the fibroid is blocking the tubes,
Yeah.
conception may be difficult.
Okay.
Okay. If it's also located in the endometrial cavity, it might cause something like miscarriage.
Okay.
And wastages, fetal wastages. But the actual sign is that fibroid per se does not cause infertility. But when you have looked at other causes and you don't have any other cause, treat the fibroid. Most of them will get pregnant.
Okay. Okay, okay. Yeah. So we can't say somebody that has fibroid, we can't say the person is doomed not to have a child.
No. Somebody can actually have a child with fibroid.
Fibroid, okay.
Yes.
Okay. Thank you, sir, for that explanation. So viewers, we'll be going on a break shortly, and when we come back, we'll continue talking about uterine fibroid. Thank you.
TSTV, connecting your world.
And welcome to Clear on Health.
TSTV, connecting your world.
Welcome back to our program Clear on Health on African Health Television on TSTV. My name is Dr. Fumilayo Elusoji. With me in the studio is Dr. Samuel Ezekwere, and we've been talking about uterine fibroids. So, Sam, before we went on the break, I asked if uterine fibroid can prevent someone from conceiving, which you answered and said no, that we had to rule out other things. So, what are some other complications of uterine fibroid?
Okay. Mostly, fibroid can present with a lot of complications.
Yes.
For instance, it can lead to what's called menorrhagia, heavy menstrual bleeding.
Okay.
And this on its own can lead to anemia.
Okay.
And then once there's anemia, the person's immunity is lowered, and then other things can come, including infection.
Okay.
And then it can also lead to pressure symptoms. For instance, it can cause, depending on where it's located. If it is located, like when you're asking about infertility and fibroid, if located in the tubes, can lead to infertility.
Okay.
In that regard, if there is tuber occlusion,
yeah,
it's difficult for the eggs to meet with the sperm, and that can lead to infertility. And then also, it can also cause pain, really during intercourse, depending on where it's located, because we call dyspareunia. And also, it can also cause painful menstruation.
Okay.
We call dysmenorrhea. It can cause it. Yes. And then also, because fibroid is a matter that is ongoing, that's the problem with fibroid. It keep on growing if you leave it. It's not a static mass. Keep on growing. It can impinge on the bladder, yes, and compress the bladder. They will now start having urinary symptoms, such as difficulty in urination, painful urination, and others. Then it can also pinch on the rectus, and then that can also cause problem with defecation. And then they also what we also call atypical presence of fibroid. Okay. Atypical in the sense that fibroid has been linked. There are some ways fibroid can lead with raised blood pressure.
Yes.
And can also lead to what we call excessive secretion of what we call erythropoietin.
Okay.
Erythropoietin. Protein is a hormone that enhances blood production. Blood cell production.
Okay.
So in that case, it can also have problems that are related to that. Okay. Then other things that fibroid can also cause is that it can also make the person uncomfortable, because before you know it, the abdomen will be so enlarged that psychologically the person will feel like she is. Other will look at the person as if the person is pregnant. True. You know, most women, they have large tummy, bloated up abdomen, and they are not pregnant. Okay. It's an embarrassment. Psychologically, it's an embarrassment. It can lead to depression, especially if somebody is looking for a child and the tummy is so big and the child is not forthcoming.
Yes. I like that explanation. Thank you, sir, for that explanation. Because beyond even the physical symptoms to deal with, we are thinking of the mental aspect of it too. So, sir, how do we treat fibroid? Assuming someone knows or has been diagnosed, how do we treat fibroid?
Well, if fibroid is not causing any symptoms, we don't bother treating it.
Okay.
We only treat what we call symptomatic fibroid. That's the one that causes symptoms. What the patient complain about. If there is no complaint, we don't treat. But there are many modalities of treatment. We have medical treatment, we have surgical treatment.
Yes.
And then let's look at the medical treatment. Normally, because fibroid grows in the environment of estrogen, so estrogen manipulation can also be a way of treating fibroid. That's why we use some drugs. For instance, we are dropping the hormone agonist.
Okay.
These are drugs that can modify estrogen production, and when you use them, they are known to shrink the fibroid size.
Okay.
But the problem with them, or the setback there, is that if you stop using them, the fibroid will grow. And number two, at times if you use them again, if you use them, they can also make the plane of the fibroid difficult to eliminate if you want to do surgery eventually. And some of these are also very expensive. And they also have their own side effects, such as osteoporosis in women. Because when they block the estrogen production, estrogen is a feminine hormone.
Yes.
The feminine build, so feminine physique is attributed to estrogen in most cases. So if you block estrogen, you know what it means? You are causing menopause in a young lady.
Yes.
And you know other things that will follow it. Then there are also other drugs, such as what we call selective estrogen modulators.
So sorry, sir, for cutting you. You said osteoporosis.
Yeah.
Now, viewers at home are not.
Okay.
So I wanted to just break it
Yeah.
down
What I call osteoporosis is a situation whereby the bone become brittle. That's become weak.
Okay.
They can easily have, especially elderly women, they can have easy fracture.
Yes.
Yes.
Okay.
Can just walk in and fall down.
Okay.
So the bone cannot support them. It's not as strong as
before.
Because it's one of the things that help the bone, help the calcium in the bone to the calcium matrix, so that you can have strong bone.
Okay.
When the estrogen is not there,
yes,
those compartments are not formed properly.
Okay.
Yeah.
Okay, sir.
Then also have what I was trying to talk about, estrogen, selective estrogen modulators. That's what drugs can also use.
Okay.
Also use other drugs like the progesterone antagonists. The example is mifepristone. What some of these things does is that they help in symptomatic management.
Okay.
For instance, reduction of bleeding, excessive bleeding.
Okay.
And then we also have, apart from these, other drugs like aromatase inhibitors. Okay. The example is letrozole. Some of these things are work on estrogen milieu and then modify it.
Okay.
Since estrogen is what feeds the fibroid per se.
Okay.
And that's why you know the fibroid is seen in reproductive age women. That's when you have estrogen more. Before puberty, you don't have fibroid. After menopause, you don't have fibroid.
Yes.
But if you have it in any of those conditions, you need to investigate properly because something else is happening. Then also have surgical option of management of fibroid, which most people subscribe to because most people that are treating fibroid are actually coming for fertility cases.
Okay.
Yeah, so we have both conservative surgery and we have radical surgery. Radical is what we call hysterectomy, where you remove the uterus completely.
Okay.
But this is actually this is what normally happens when a woman has completed her family size.
Yes.
Is having fibroid issue.
Yes.
So it can be cancelled on that if she chooses. Then, but the other conservative management is what we call myomectomy, in which you just open up the woman and then remove the fibroid and leave the womb intact.
Okay.
It can be done by open surgery, also done by laparoscopy, or even by hysteroscopy, depending on where the fibroid is located and the size of the fibroid. And the expertise of the person handling it.
Yes.
Yeah.
I think let's break down laparoscopic and hysteroscopic.
Okay.
For our viewers at home.
Yes.
Yes,
Okay.
Sir.
We're going to call. I don't know. Let me use the word to call now minimal access surgery. In other words, surgery that is not that doesn't involve cutting the person too much.
Okay.
Before now we do what we call open surgery.
Yes.
If you have fibroid, they cut through your abdomen from the skin down and then open up the whole thing, remove the womb, locate the fibroid, excise it, close up, and that's all.
Yes,
but
sir.
these days now, with advances in technology, such a thing can also be done without actually opening the woman
Yes.
in actual sense.
Yes.
What we call pinhole surgery.
Okay.
Just a small hole created in the woman's abdomen, through which some instrument may be passed, and then get to the woman's womb, and then the fibroid is enucleated, macerated, sucked out,
Yeah.
and then you close.
Okay.
That is laparoscopy. Then the hysteroscopy is the one who will go through the private part, the vagina, go to the vagina, to the uterus, pass through the vagina. Laparoscopy, go through the abdomen, go through the womb, pass the instrument through the cervix into the womb, and then usually it's advocated for fibroid that are sub-mucosa.
Okay.
Certain grades of, not all of them, but certain grades of sub-mucosa fibroid.
Okay.
Yeah,
Okay.
can be done through that.
Okay, sir. Thank you so much for that explanation.
Then there is also another modality of treatment these days I will call, whereby, fibroid also is highly vascularized tissue. Yeah, so you can also starve fibroid of blood. Something like, we call it uterine artery embolization. In other words, the blood that supply the uterus is uterine artery. That's the blood supply to the uterus, uterine artery. You can also block that artery using some particles, some polyvinyl chloride. They are used to block it. When you block those the channels, you starve the fibroid of nutrient. The fibroid can start shrinking. It has its own side effect as well.
Okay.
As well, we also what to call uterine embolization.
Okay.
Ablation, not ablation. Not ablation, was embolization. Then ablation, whereby if fibroid is located in the uterine cavity, it can actually be burnt off. Yes, that's called ablation.
So that it has to be outside, within the
uterine cavity for you to do that.
Okay.
The ablation.
Okay.
You must do it through hysteroscopy. Just locate the fibroid and then destroy the fibroid tissue.
But that's within the cavity of the uterus.
Yes, within the cavity.
Not the muzzle.
No, the muzzle will be difficult to do that.
Okay. Okay. Thank you, sir, for that. Then I know we've already talked about treatment, but I wanted us to talk about how we diagnose uterine fibroid.
Okay.
Because that's very important. Because we know that some people's tummy will not grow big.
Yeah, right.
Yeah, some people may not even have that obvious painful menstruation or pain when having sex or all those pressure symptoms you mentioned. But how else, what's the standard way to diagnose it, sir?
Okay, I know when we talk about diagnosis medically,
yes, sir.
It starts from history,
okay,
then physical examination, and then auxiliary investigations.
Okay.
Then history per se, a woman may come to present with things if you find that these are part of the history you're going to take. And then also the history of symptoms, other complications of fibroid, like urinary system problems, or how to do the rectum, or even pressure symptoms. One can present any of these. And then you also carry out your physical examination. Obviously, if a woman is not pregnant, it doesn't matter the size of the woman. If you examine the woman, ideally, you're supposed to palpate the womb.
Okay.
The womb is a pelvic structure.
Yes.
So if you put your hand when you're looking at the abdomen, you not palpate the womb. By the time you see the womb coming into the abdomen, and the woman is not pregnant,
yes,
it calls for consign. So that will also now give you an understand that something is happening, and you may need to investigate further.
Yes.
With the history the woman has given you, and then you can also now go ahead and say, okay, let me investigate her. The commonest thing we do here is we do ultrasound. I'll do basic ultrasound. Ultrasound will be able to delineate the fibroid, show you the size of the fibroid, show you the location of the fibroid, and the number of the fibroid.
Yes.
Ultrasound can do that.
Okay.
Or you can, if you don't want to do that, that's the commonest thing we do. But there are other radiologic investigations you can do, like magnetic resonance imaging, MRI.
Yeah.
Also do computerized tomography. Those things can also be done, but they are more expensive.
Okay.
And we don't actually do them mostly. With ultrasound and obstetric ultrasound, you can actually detect fibroid.
Okay.
And then if you do that, you can also now do other tests that will enable you prepare the patient depending on what you intend to do.
Yes, sir.
For instance, if it's a small size fibroid, that's not of any concern, you may not do anything. We just ask the patient, okay, we'll follow you up. We'll monitor you every 6 months, every year, things like that. You follow the patient up. Or even I completed his family and the symptom is so much.
Yes.
And now it's okay, let's walk you up for surgery. And in that regard, you have to now do other tests. That would determine surgical fitness.
Okay.
Hemogram, X-ray, and all those other things that enable you to know
Is this person
fit for
our
surgery.
surgery?
And then if that's the case, you walk the person up for surgery, depending on the patient's consent.
Okay.
And then if there are other symptoms that are there, that also guide the extent you're going to go while investigating the patient. And then also it depends on the patient's choice. But whatever you want to do, you must get patient's consent. Yeah, yours is just to table the whole matter before the patient, and then the patient make her final choice. Patient and the family make their final choice.
Yes.
Yeah.
Yes. Thank you, sir, for that explanation. So, sir, we talked about medical and surgical management.
Yeah.
Is surgical management, is it dangerous to the patient? Because a lot of patients know they have uterine fibroid, they've been diagnosed, they are having symptoms, they see that the fibroid is increasing in size, but they are just afraid to do the procedure. Is this operation dangerous?
Ah, okay. Really, it's not.
Okay.
Actually, because of our level of literacy, a lot of stories are being circulated at the background. People just tell all manner of stories about fibroid and even surgery. And we're living in an age whereby there are advancement in science. This has improved so much. Now, you can actually do fibroid surgery. The patient go to his house or her house, go to her house in the next 3 days.
Okay.
This has improved so much. So fibroid surgery is not a dangerous surgery, but you need to choose your patient accurately. You need to also work up your patient. You need to prepare your patient. You need to also have the relevant skill.
Okay.
It's something that the specialist should do.
Okay, so
not just anyhow person doing it.
So the patient should know the doctor.
The right person to, right place to go.
Yes, so it's not
qualified.
just any doctor that should do.
No, because there may be problems which you must know how to handle.
Yes.
For instance, fibroid is a bloody surgery. Let me use the word bloody surgery because of the context we're discussing it now. At times you may notice that you have done the fibroid, the woman is bleeding. You must know what to do.
Yes.
And if you don't know, that's why you say, the woman has died after fibroid operation. But if you know what to do now, you must have woke up your patient. You must have made sure that blood is available. You must have made sure that when you enucleate the fibroid, you close the dead space completely. And make sure that you secure hemostasis, or you can close the abdomen.
Yes.
But if these things are not done, that's where you have complications. Understand?
Yes.
And then beside, people talk all manner of things, but the truth is that it's a safe surgery.
It's a safe
in a safe hand.
So viewers, fibroid is a safe surgery
yes,
when you have someone that knows how to, do the surgery and is trained to properly, carry out that surgery. Yeah. So, sir, I wanted to ask one last question before we go on a break. Okay. Can fibroid cause cancer? Because I think we have to emphasize that fibroid is a benign tumor. Okay. It's not cancerous.
Yeah.
Yes. So, can it cause cancer?
Oh, yeah. Okay. Fibroid is a benign tumor, but in less than 0.001%,
yes,
it can also be cancerous.
Okay.
That's why when you notice a fast-growing fibroid, it's suspicious.
Okay.
When you notice fibroid in postmenopausal woman, it's suspicious. You need to investigate further.
Okay.
So in such cases, you must investigate. Okay. So in the range I have mentioned, that percentage, it can.
Yes.
Yes, but mostly fibroid is a benign tumor. Mostly a benign tumor. Okay. When you see it happening in the extremes of life, call for concern. We need to investigate.
Okay.
And make sure it's not cancer.
It's not
cancer.
Thank you for that explanation. So viewers, we'll be going on a break shortly, and when we come back, we'll keep talking about uterine fibroid. Thank you.
recharge your TSTV decoder, simply log on to www.buytstvvouchers.com. Click on sign up, fill in your details, name, email, phone number and password. Click on create, then log in with your email address and password. Click on buy voucher, select the voucher of your choice, pay with your card or wallet. Enter your decoder serial number and voucher pin, click on load, or you can get your TSTV voucher from our dealers nationwide. You can also contact Kalak Power on numbers and details showing on the screen. TSTV, connecting your world.
And welcome to
that you may not